Yeah, so using CAT scans as a means of diagnosing gout is a technology that has just recently emerged, and we basically asked the question, how good is this technique? So how reliable do we find patients who indeed have gout, and are there cases where we erroneously diagnose gout in patients where they actually don't have gout? So the typical questions that you would ask for any new diagnostic test. And then the second main question was how much this particular test would contribute beyond the routine testing that we currently have available, such as drawing fluid from an affected joint and looking under the microscope whether gout crystals are present. We found that overall the CT does have good diagnostic properties, so we are able to pick up a large amount of patients who actually have gout, and we overdiagnose gout in only very select and few cases, but there are caveats to this technology. So in patients who have very acute new onset gout, never had a flare before, you can actually miss cases. And in patients who do have very advanced degenerative disease of their knees, we found false positive signals. So physicians have to be very careful when they're utilizing this technology in patients with advanced osteoarthritis of the knees. What can the new test, the more expensive test, contribute beyond the routine diagnostic approach that we currently utilize? And we found that in about 30% of patients who did have a negative routine diagnostic test, so pretty much joint aspiration, we actually did find evidence of gout. So these were in part patients that had been falsely diagnosed with diseases such as rheumatoid arthritis, so pretty much labeled with a different type of inflammatory arthritis, resulting in a completely different, often not effective treatment approach. And there were patients who remained undiagnosed for many years with, let's say, chronic elbow symptoms or Achilles tendon symptoms, where the CT scan then helped us to pick up uric acid deposits in those structures. Gout is actually the most common inflammatory arthritis in men and in women, and it by far surpasses its closest rival, which is rheumatoid arthritis. So we currently believe that the prevalence of gout in the US population is around 4%, and it has dramatically surged since 10 or 20 or 30 years ago. So, for example, a study that we have done here in the Olmsted County database demonstrated a doubling of disease prevalence between the 70s and the 90s. So over just 20 years, the disease burden has approximately doubled here in Olmsted County. Well, I believe it has something to do with the surge in obesity rates and the surge in unhealthy diets. So there's a close link between obesity and the frequency of higher uric acid level in the blood and then subsequently gout. Gout is more frequent in men, and especially it's more frequent in particular age groups. So the biggest difference between men and women we see between the age 20 and 50. But before the age of 20, where gout can actually also occur, disease rates between men and women are similar. And after menopause, women tend to catch up. That has probably something to do with the effect of female sex hormones on our ability to excrete uric acid. The first flare of gout most commonly occurs in the big toe, so this is correct. But gout can affect pretty much every joint in the body, and the more gout flares you have, the higher likelihood that other joint areas will be affected. And again, it can pretty much affect every joint in the body, the elbows, the wrists, the hands, the knees, the ankles, the feet. What we're learning from those dual energy CT scans, which now enable us to really depict uric acid deposits in various structures, has really changed our perception of where gout can occur and how it can manifest. So I think now the ability to visualize those deposits really broadens our perspective on gout.